Start up right now. Good evening, everybody. It's 5:30 p.m. here in India, and it's a pleasure for me to be able to connect with surgeons all across Southeast Asia. The topic that I'll be talking on today will be diseases, lung diseases, congenital lung diseases in the pediatric population. As part of the cardiac and thoracic surgery program, where we've been trained to do everything right from thoracic and pediatric. I used to do exclusive pediatric work when I was part of the Children's Hospital in Atlanta as well. And we've carried on to do that. So thoracic and pediatric work form around 20–30% of my work on a day-to-day basis. So without much ado, let's just have a little idea about what's going on congenital disease of the lung. So right from the 1950s, we've seen an array of changes in approaches to surgery, right from pneumonectomies through Gross's, lobectomy for a lobar emphysema, all the way to 2003 when Rogers started excising bronchogenic cysts in children thoracoscopically. So at one end we had this, and at the other end we had the advent of the exit procedures, more fetal surgery in combination with their pediatric surgeons. We've been able to do these procedures for CCAM lesions with high drops. So I think, congenital lung diseases are very important. However, they are rare, but the reason they are important is because they have considerable morbidity and mortality in the population that they affect. There is a significant amount of infection, recurrent hospitalizations, hemorrhage, respiratory failure. And to be honest, they form around 5 to 20% of all congenital anomalies across the spectrum. What's important to note is that the prognosis of these lesions depends not only on the size of the lesion, but also to the amount of functional impairment that they've caused the patient. So to just simply put it across the board, there are 4 kinds of, lung diseases we're talking about. One is those related with a foregut component anomaly. The other is with airway component anomalies. The third is with parenchymal anomalies. And the fourth is those having vascular anomalies. So put in for just a couple of things that I will be touching upon are bronchogenic cysts, sequestration, CPAM, also known as CCAM, lobar emphysema, bronchial atresia, and AV malformations apart from the Scimitar syndrome. So let's dive right into the topic. So let's start with bronchogenic cysts. Everybody knows they're closely associated with the foregut. It's a foregut duplication, and there's an abnormal budding of the ventral foregut. So much so the duplication cysts that are associated with esophageal duplication as well. They can be central or peripheral. A lot of them are mediastinal, almost 85% of them. They may be either filled with fluid or rarely with air. Many of these bronchogenic cysts are asymptomatic, and when they do cause symptoms, it's because of respiratory distress, dysphagia, chest pain, or epigastric discomfort. And when the symptoms arise, it's because the secretions in the secretion from mucous glands fill and expand the cyst, and that in turn puts pressure on adjacent structures. The respiratory distress that we have could be just mild in the adults with just a simple cough or an infection sometimes, or it could be life-threatening in infancy. And what's important is that these intrapulmonary cysts can sometimes communicate with the tracheobronchial tree. And when that happens, the risk of infection is pretty high. So when it comes to bronchogenic cysts, the simple rule of thumb is almost all of them who are symptomatic need surgery. When it comes to asymptomatic cysts, there are 2 kinds of approaches. The world's kind of divided between those who advocate surgery and those who advocate simple serial follow-up. Now, what is the problem with simple observation? As Fetal and Biscotti have said, that 45% of these people eventually become symptomatic because the cysts grow in size and they cause compression on certain other structures surrounding it. So most people, including Kermani and all, feel that surgery is better, especially if the cyst is voluminous, if you see early signs of compression, or definitely if there's some kind of communication with the bronchial tree. So resection is the treatment of choice, and resection is needed because there is a potential for infection, for hemorrhage, for any kind of compromise, like I said before, and there is a small but real-time risk of malignant transformation. Now, resection is more common and more important in peripheral regions, but sometimes can be multiple. And as Rogers was the first one to perform at VATS, these can be frequently excised thoracoscopically as well. Important to know at the time of surgery is they seldom have a major blood supply. They draw the blood supply from the surrounding structures, and that can be easily dealt with the harmonics. So it's easy to do it thoracoscopically. Now, complete total excision is the goal. What is near total excision? Now, near total excision was in certain situations when it's not possible to excise the entire wall of the cyst. Now, this happens when a certain wall of the cyst is, fused to the esophageal membrane, sometimes to the tracheobronchial membrane, and as I've seen it at times as well, to the pulmonary veins. So when that happens, after removal of the cyst lining in the cyst wall, we try and apply some kind of a chemical ablation or cauterization on the wall that's left behind so as to prevent any kind of recurrence that happens. Of course, the goal is to take a near total excision, and only that part of the membrane that's fused with the membrane, with the tracheobronchial membrane of the esophagus can be left behind. So what is non-surgical treatment? Well, it has been advocated by certain members who feel that, when the patient's inoperable or where there's an urgent need to decompress the cyst, we can either aspirate it or instill a sclerosing. Of course, we need to understand that this does not lead to a definitive cure. So let's look at some of these cysts out here. Here is a subcarinal bronchogenic cyst. And the same thing also shows that there is A-trapping as well as hyperinflation distal to the point of obstruction. This cyst was excised totally by a VATS excision. This particular patient had large cyst, which was more, very close to the esophagus. Some part of the wall was very fusely adherent to the esophageal wall, and it was not possible to remove it totally. And a subtotal excision, as I discussed before, was what is performed. This is intrapulmonary bronchogenic cyst, a VATS right upper lobectomy was what was performed for this patient. Now, what is pulmonary agenesis? Now, pulmonary agenesis can be accompanied by certain renal anomalies as well, and because of which they present rather early, soon after birth. There is associated with respiratory distress. And important to understand is there's a lot of comorbidities as well. There's almost 50% of them have cardiac defects. They can even have parts of the vacuole syndrome, more commonly on the left, and it's almost lethal in 50% of the patients. What's differing a lung agenesis from a lung aplasia is the presence of the carina. Over here, agenesis has a carina and aplasia does not have a carina. Pulmonary hypoplasia, the development of the lung tissue distal to the point of the bronchus is incomplete. The earlier the delivery of the child, the more premature the child, the higher the incidence, so much so that less than 28 weeks of gestation, the incidence is almost 20%. And it also can be secondary to certain factors that restrict the growth, like Porter syndromes, anomalies of the thoracic cage, like hydromanose, or the Scimitar syndrome again, or even a diaphragmatic hernia, usually left-sided. So there are three kind of groups of presentation of patients with pulmonary hypoplasia, and group one is the one who are the severely affected. They have insufficient lung tissue for them to survive. Many of them have received mechanical ventilation, and they either have ventilator-induced injury, which slowly causes decompensation and death. So this kind of group of patients are usually fatal, the one that I spoke about earlier. Group 2 and Group 3 are different. They do not require ventilation. Group 2 is the one which is incidentally detected, and most of the time just requires no intervention. It's always good to follow up on these group of patients as they grow into adulthood. Group 3 are patients who have respiratory limitations, and these limitations may be either due to the activity that they have, the kinking of the airway, and some amount of mediastinal shift to the contralateral side. So this is an X-ray of a patient who had a Group 2 incidentally detected. The CT scan helped identify the hypoplasia. Nothing was done except medical management and serial follow-up. What is pulmonary isomerism? It's an anomaly of the number of lobes. Very commonly, the right and left are switched. The right has 2 and the left has 3 lobes, and it's associated with situs inversus, asplenia, and a lot of times anomalous pulmonary venous drainage. Sometimes can be associated with IVC interruption as well. The azygous lobe, coming onto that, it's more a radiologic curiosity that occurs in a small percentage of the population, and it's a malformation in the right upper lobe. There's an aberrant azygous vein that's suspended by a pleural mesentery, and they cause a small little separation of the lobe called the azygous lobe, and really nothing really needs to be done for it, and just to follow up. So let's go on to the next set, and that is pulmonary sequestration. It forms around 6% of all congenital lung malformations, and although it comes early in childhood, you have presentation as late as in their 40s and 50s as well. So what we need to know about this, it most commonly occurs in the lower lobes, and there's a bronchopulmonary mass without a normal communication with the bronchus, but however, it has either a normal or anomalous vascular blood supply, classified into intralobar or extralobar with lobe, or also on the basis of the pleural coverage into intrapulmonary or extrapulmonary types. So intralobal sequestration, it happens in 75% of all sequestrations, very commonly in the lower lobes, especially the left side. Rarely we have some anomalies of the heart or the diaphragm or even the skeletal system in around 1/10 of patients. Now, the aberrant artery is very important, it's very unique, and a lot of the times it originates directly from the thoracic aorta. This is very important from a surgical aspect because it's usually neurismal, it's very fragile, it's got a high amount of elastic content, and during the time of surgery, if you're not careful, it can easily retract back into the tissues, and it's very difficult to find after that. So it's important to identify this, and I'll speak a little more about it as we go on. These particular slides show an arterial supply from the thoracic aorta for left lower lobe sequestration, both in an axial and a cross-sectional view. This particular intralobar section, earlier we used to diagnose all these kind of things, when the child is older, when they're coming in much later, but now a lot of prenatal ultrasounds fix these masses, or echogenic masses, on ultrasound, and when indicated, some of them require an MRI, and this shows a small little sequestration mass with an arterial supply coming from the thoracic aorta. So a lot of the times the pediatric population, when we follow them serially with MRIs or ultrasounds, a lot of them regress, almost as much as half of them. Sometimes they tend to present right into the neonatal and infant period. Now, if we have a pleural shift or mediastinal muscular problems of hydrops or hydramnios, then we know that some kind of intervention may be required earlier on, and this may require intrauterine shunt or some kind of a pleural amniotic shunting or an ablation of the aberrant vessel. Now, when the diagnosis is done in the newborn, obviously we try and wait and delay the surgery because the children will tolerate the anesthesia, and obviously postoperative morbidity is much lower when the age of the child is around 6 months of age. If asymptomatic, however, two advocates, one is early surgery, the timing is debatable, the other one is serial follow-up. Whatever it is, the goal of the surgery is to prevent the possible complications that are associated with the sequestration, and most commonly recurrent infection or pneumonia. Sometimes you can have hemoptysis or bleeding, a cardiac failure if there is a AV malformation, AV shunting that's happening with that. And of course, the association, a small but real association with an adenoid cystic malformation, which itself has a true malignant potential. So this particular MRI over here being demonstrated shows presence of cysts, left lower lobe, and when a gadolinium contrast MRI is performed, we see an early venous return into the left pulmonary vein, indicating a high cardiac output state because of an AV malformation that's pseudo-formed because of the blood supply there. So when the diagnosis is beyond infancy, resection is indicated for the same reasons that we spoke about, and that is primarily to prevent the infection and cardiac and congestive cardiac failure, as well as any kind of respiratory distress. Commonly, lobectomy has been performed, but for people with intralobar sequestration, segmentectomy is also an option. Of course, it has a little more morbidity as compared to a lobectomy, because there's a lot of adhesion between that particular segment and surrounding tissue. Coming to extralobar sequestrations, they form 25% of the sequestrations. 90% of them are on the left side. Again, most commonly the posterior CP angle, very rarely in the mediastinum below the diaphragm. 30% of them may be associated with a diaphragmatic hernia, and more importantly, 50% of them have an association with adenoid cystic malformation. So obviously symptoms are rarer than an intralobar because they're not directly connected with the lung, but even asymptomatic asymptomatic patients need surgery to prevent the complications that I spoke about. Once again, extralobar sequestration demonstrated in this MRI with a contrast showing an arterial supply from the thoracic aorta. So in many sequestrations, obviously the mass is air-filled and it's easy to separate from the other lung tissue to identify it. Sometimes it's very important to find the supplying artery, and many times if the MRI doesn't pick it up, it's important to get an arteriogram or a CT arteriogram to see the blood supply and identify it, especially if it's below the diaphragm. It's possible to do that in children, and obviously the working space in small chest, we all know while the lungs are being ventilated is always a challenge, and also handling delicate pulmonary vessels is another challenge that we need to see. Coming to a vascular anomaly that we see sometimes is a Scimitar syndrome, and this particular syndrome is because there is partial total anomalous pulmonary venous return to the inferior vena cava, that's the systemic circulation rather than the pulmonary circulation. And it's also associated with lung hypoplasia, because of which there is pseudo dextrocardia or dextroversion as we call it, and the patients may have other cardiac anomalies as well. So when the symptoms of Scimitar syndrome are basically related with shunting of the anomalous vein, the surgery can be done for rerouting of it, but if it's related to lung complications like bronchiectasis or chronic infection, sometimes a pneumonectomy has to be done. So this particular paper is my own paper from maybe around 15, 16 years ago. A young gentleman with a pseudodextrocardia, lung hypoplasia on the X-ray, had a CT scan which showed the dextroversion, and the CT angio that showed an anomalous venous drainage. This was further quantified with a right heart cath study. It showed the pulmonary venous return to the IVC. In addition, had an anomalous left upper pulmonary veins going to the innominate vein via vertical vein. All this was operated just by rerouting. The lung on that side was quite good, although it was hypoplastic and nothing really needed to be done. So this is one of the examples, just a cardiac rerouting was required, and the lung pathology did not require any other treatment. So let's go on to the next vascular malformation. It's pulmonary AV malformations. There are abnormal communications between the arterial and venous system, and obviously the lack of interposed capillaries means the blood goes directly from the venous to the arterial system, resulting in a high output cardiac failure. The symptoms are usually unusual in childhood, and as the shunt increases with age, that's when they can present with congestive cardiac failure. Sometimes it's noticed as a small mass on a chest radiography, and the resection is usually performed when the diagnosis of the mass is not known. Sometimes when it's close to a bronchus, you can have airway obstruction as well. So let's move on to another entity called the alveolar capillary dysplasia. It's something in which the alveolar circulation is impaired, where the arterial blood supply is reduced. The pulmonary veins are not aligned to this blood supply, and the intervening capillary endothelium, that's abnormal as well, and the thickness of that is increased. All in all, the response to nitric oxide is poor. It's a very faint condition, and although patients do well with the ECMO on, but they just can't be weaned from it. Another condition that we see on and off, more common in women, pulmonary lymphangiectasis. It can be part of a syndrome of many lymphangiomas in other organs. Usually symptoms don't come till childhood. The symptoms of respiratory insufficiency. All this is related to the abnormal pulmonary lymphatics, which are dilated, can have rectal diffusions as well. If it's located to one particular segment of the lung, lobectomy for that segment can be done. More or less, it's generalized when the treatment needs to be conservative in nature. Let's go on to the next large entity that we see, congenital lobar emphysema. It's a massive inflammation of one of the post lobes that is seen postnatally. It can be related directly to an anomaly of the bronchial cartilage, which causes a one-way valve or A trapping within the lung. Very common in the upper lobe, more on the left side, and rarely on the right side as well. Lower lobes are rare. Most of the babies present before 6 months of life. The neonates may have, a mediastinal shift, respiratory distress. Infants may present with cough, wheezing, and older children may just have rectal respiratory infections. It's very important to see a particular X-ray that we see, because there can be a differential diagnosis. I'll just show you the X-ray. You have a hyperlucent left side, overinflated, mediastinal shift. So a differential diagnosis, obviously the most common anomaly that we see on this is the tension pneumothorax, but we must consider a congenital lumbar emphysema, especially if it's in a newborn. And a prompt thoracotomy relieves the pressure inside the hyperexpanded lobe, And the hyperexpansion itself stretches and makes the dissection for lobectomy much easier. In cases that are detected early, or just because of the radiological symptoms, sometimes the lung may not be that overinflated, and it may be difficult to find that during surgery. So here's an acute presentation with congenital lobar emphysema, noted on the right side. Over there, the CT scan shows a grossly overdistant medial lobe, causing mediastinal shift, and post-thoracotomy, right middle lobe is removed. So more moderate cases, like you can see out here, there is some amount of mediastinal shift and some secondary atelectasis of the lung on the opposite side. Depending on the symptoms, it can be serially followed up or can be taken in for a surgical correction of the same. Asymptomatic cases sometimes present to us, and all we need to do is conservative management because a large number of lesions regress over time. Coming to an important one now, CCAM, also known as CPAN. 25% of all congenital lung malformations are related to CCAM, and very commonly cause respiratory arrest in the neonatal period. A lot of them appear cystic because they get ventilated by the surrounding pores of con. They have mediastinal shift, sometimes can have a pneumothorax. They can be polyhydraminose or hydrops fetalis associated with it. Important because it causes recurrent infections, and malignancy can definitely occur, although there have been debates about the malignant potential, but bronchoalveolar carcinoma to blastomas and sarcomas can occur as well. So Stoker's classification, just a small note on it. Type 1 is the large cyst, visible. Type 3, microcyst, not visible, looks like a solid organ there. And type 2 is in between, cyst not larger than 2 centimeters. What's important is that most of the patients at birth with CCAM are asymptomatic, but by the age of 10 or 12, most of them are symptomatic. There's no doubt about the consensus on surgically treating them in all symptomatic patients. Asymptomatic patients, again, debate between operating or not operating, especially risk of operation in younger children could be higher. Many of the times we feel that, the advocates for surgical patient is because, there's a recurrent infection, there could be hemoptysis. We want to avoid pneumothoraces and to avoid the malignant potential. And many of the people who advocate medical management have been more for, the exaggerated malignant transformation potential, which may not be true, and advise serial follow-up of these patients. But I, for one, believe that surgical approaches to these lesions is the far better approach. Sometimes when they're seen in the fetal ultrasound and when they confirm an MRI, we can have a surveillance to see how they grow, whether there's any pleural effusion or mediastinal shift. And if at all, we can have the joint work of a pediatric surgeon along with this to have any kind of an exit procedure for fetal surgery. So this particular MRI shows a cam on the hypersignal on the right lower lobe. This particular child born with a large cam on the left lower lobe, presenting with acute respiratory distress. A CT scan shows large cystic fill lesions, as well as a small pneumothorax as well, complete shift in hypoplasia of the surrounding lung. In older children, when the presentation just comes as a large mass, this patient had recurrent infection in infancy, usually a good functioning class, and when they're symptomatic, I for one advocate the surgery rather than just medical treatment for the lesions outlined before. Last but not least, we can talk about lung cysts. The lesions, they can form in any part of the lungs, they're usually simple cysts. What's important to know about them is resection is performed, one, to prevent their progression and also to diagnose the lesions. And it's not unusual that a lot of them that are found to be simple lung cysts are actually cystic adenotide malformations. Sometimes they can just be shelled. If they are not a small segmentate, we will be able to take them out. Sometimes just a figure of 8 sutures can also help stop the lung system. Important, whatever surgery we do, we need to make sure that we avoid the formation of the bronchopleural fistula. Polyalveolar lobe, for the completion sake in congenital lung diseases, it's something that can be associated with congenital lobar emphysema. It's nothing but a larger number of alveoli that are present towards the terminal bronchiole, and they're filled with fluid, sometimes look cystic as well in nature, and essentially a benign anomaly when indicated requires nothing more than just follow-up. So all in all, I think that brings me to the end of my presentation. I hope I've kept to time. This is the hospital that I work at, Sakra World Hospital. It's a 100% Japanese hospital in India that's owned by Toyota. This is the city that I live in, Bangalore. It's got a mixture of traditional architecture, as well as it's known as the Silicon Valley of India. most welcome to a lot of the team members for questions, and also visit to a center anytime that you would like. Thank you for your time and patience. Over to the moderator.
So thank you very much, Dr. Adil Sadiq, for your very widespread, you cover a wide area of knowledge of congenital lung diseases. And I think there are many Q&A, and this will be after the second speaker. Now, so you unshare your slide, please. And
yes.
So the second speaker will be from Vietnam, Dr. Vu Huu Vinh. So actually, he's my friend, and he visited me for operating some tracheal surgery successfully. And let me introduce Dr. Vu Huu Vinh. So he's a famous Vietnamese general thoracic surgeon from Cho Ray Hospital. And so he has been trained in Japan, and he got the PhD from Japan. And I think he did many operations, and his interest is even lung, esophagus, and he is popular in tracheal surgery as well. And his particular interest is on chest wall and chest wall reconstruction. So without wasting the time, let me invite Dr. Vu Huu Vinh for your presentation on congenital tracheal surgery. So Vu Vinh, please.
Okay. Good evening, everyone. Thank you, Professor Tint, for the very kind introduction. And I think most of the audience today is adult thoracic surgeon, but we have two congenital presentation. So in the second presentation, I will speak in very briefly. And also thank you, SIT School of Surgery, for having me with this webinar program. Okay. Now, let's start. So briefly, my content will have four parts. The first, anatomy and pathology of tracheal malformation, and the second is classification or type of tracheal malformation. The third one, I will say something about the surgical technique, how to indicate our indication and the technique. And the last, I will talk about our result in the 5-year series of surgery. So first, briefly, as you can see, is the image of congenital tracheal or bronchial malformation. It's many kinds of the shape. And this is anatomy and pathology of tracheal malformations. First, we have to say about the anatomy. So in the anatomy, there are several kinds of congenital. The first is abnormal in the tracheobronchial tree, and the second is the shape is different. But I'm sorry, I say again. The first is no change in the shape of tracheobronchial tree, and the second is a distortion about the tracheobronchial tree. And both types that will have some part stenosis in the tracheal or bronchus part, and it makes obstruction to the air come to the lung. And the last one is there is only one lung, and it means that only one bronchus. So you can see in the image, variety kind of tracheobronchial image. And for the pathology, all of kind of this abnormality will obstruct the air come to the lung, and it makes the children very easy to get pneumonia. And sometimes the children have a stridor of dyspnea, like asthma, and the patient is repeated go to the hospital because because repeated pneumonia, and in the last one they may get in the ventilator and intubated and ventilator. Okay, how about the classification? Before there have been several kinds of classification. But at last, most authors agree that it should be divided into the 4 types only. The reason is the new classification is to serve the surgical repair. And as I said before, there are 4 types, but the first is a normal abrasion. It means that no change in the tracheobronchial tree. But in the tracheobronchial tree, there are some part of them was stenosis. And the second is there are small chain. So they have, the children have a separate branch arising directly from the trachea to supply to the right upper lobe only. The remaining is no chain. And the type 3 is 3 distinct bronchi arising from the same level. We call it tripod carina. And the fourth, the type number 4, is absent of one lung, or including the absent or maybe vestigial, like a bud of other bronchus or bronchies. So this is type number 1. Type number 1, at the middle, you can see the normal tracheobronchial tree. It's normal. And in the children, you can see 4 images, A, B, C, D, also the same shape. No chain in the shape of trachea, but in some part of the tracheobronchial, there are stenocytes. They may have maybe one single stenocyte or maybe multiple stenocytes. Stenocyte may be in the upper part of trachea, maybe in the lower part of trachea, maybe involved in the both bronchi, or maybe only one bronchus. So number A is tracheal, the lower part, with the both bronchi was stenocyte. So it looked like a sausage. Number B is upper part of trachea. Number C is the lower part of trachea. And number D is very, very long, almost trachea was stenocyte associated with the left bronchus was stenocyte. So type number 2, as I said before, there are a separate bronchus arising directly from the trachea, come to the upper lobe on the right side, and there remain no chain. It means that the lower lobe and middle lobe on the right side have their own bronchus, and the left lung have their own bronchus. This type have several other terms because the shape is not as beautiful as the previous slides. So in this slide, you can see they have other shape. So because they have many kind of shapes, so they was termed differently by many authors, including us. We use as the double carina, you can see in that is our term, because it looked like 2 carinas, upper carina and lower carina. But maybe you can see in the literature or other publications, the tracheal bronchus, it means that the bronchus arise directly from the trachea, or maybe bridge bronchus. So you can see between the upper carina and lower carina, there are bridge bronchus. This is the bridging between the two carina. And this bridge is the most stenocyte part in this anomaly. The type number 3, you can see 3 distinct bronchi arising from the carina at the same level. So look like a tripod. As you can see on the tripod in the camera, it looked like a tripod. And of course, on the right side, the 2 to the right side and the 1 to the left side. And the 2 to the right side, and the 1 is go to the upper lobe, and the other go to the middle and the lower lobe, the same as the previous type. And the type number 4 is not related to the lung. It's for bronchus, because the previous speaker have talked about the congenital lung disease, but I'm talking about trachea only. So because the children have only single lung, so they also, he or she also have a single bronchus, only one. The other bronchus, you may see such a vestigial only, or maybe no. In this child, they have a left lung, and there are only trachea and bronchus the same, come to the lung. And you can see nothing in the right side. Associated with tracheal malformations, sometimes have another anomaly, maybe in pulmonary artery or cardiac anomaly. So the most important, the common associated with tracheal malformation is pulmonary malformation, and we call it sling, like the same sling in our backpack in the shoulder. So normally the pulmonary artery divides the left main pulmonary and the right main pulmonary, and in front of the trachea. But in this anomaly, the left main pulmonary artery did not go to the left side in front of the trachea, but they sling behind the trachea, between trachea and esophagus, and go to the left side later. So you can see in the upper part is there are 2 children, two patients. On the left of the screen, you can see the pulmonary artery was compressed, very small. And on the right side, you can see the pulmonary artery is very big, but trachea was compressed. So when some two slings together, one of them will be compressed, but trachea always was affected. And if the pulmonary sling, most of the sling children have a tracheal stenosis. And in our series, and in our series of surgery, and also we have a 63% of the congenital tracheal malformation associated with the pulmonary artery sling. So it is very common. Other association may be ASD or VSD, or the atrial septum defect or ventricular septum defect, ASD or VSD. And another maybe in the abdomen, maybe imperforated anus, there are no anus. And we encounter several kind other anomaly associated with the tracheal anomaly, but most is a pulmonary artery sling. Where is sling located? And so you can see the slings in the upper image and the lower image. The sling is indifferent. If the trachea was in different shape, in the no chain, it means that no chain is a shape. The sling is always just above the carina in the lower part. But in the double carina children, the sling is above the second carina. It's between the upper carina and lower carina, and sling to the breath bronchus, as I said before. Yes. So where does the ductal arteriosus locate? So you can see on the left side, it is incorrect. I take it from a textbook, and in this textbook they draw a ductus connecting the left pulmonary artery to the aorta, but it's not correct. In our series, we did not see any kind of like that. But on the right side, it's correct. The ductal arteriosus connecting the main PA to the aorta. This is very important for when you perform surgery for the children. And that is the reason before we always transect the ductal arteriosus, but now it's not necessary because it doesn't affect about the repair surgery. So now the later cases, we don't transect the ductal arteriosus anymore. And for the clinical symptoms, so most symptoms like the children like asthma only, but it's not always was diagnosed. Many children come to the hospital with a diagnosis of asthma. They have some stridor of exhaustion or severe distress, but in our country before, the children was very rare to take a CT scan or bronchoscope, so they was diagnosed asthma only, and after severe and get ventilated, or maybe they get a cardiac surgery and they detect the disease of tracheal malformation congenitally. And this is also the different abnormality was repaired differently. The technique for that, because the main topic today is to talk about the surgery. And to perform surgery for this kind of children, we need sternotomy, and also the patient put on the heart-lung machine or the cardiopulmonary bypass. And then we do sternotomy, and we expose the aorta and the pulmonary sling and trachea. And but different type of anomaly will require different type of surgery, the technique. And I will tell about it a little bit later. And for the tracheal malformation, the very famous technique is slide tracheoplasty. So in this image is the post after surgery for a slide tracheoplasty. And this is technique. Sliding technique always related to the name of Dr. Sang and Grillo. And Dr. Sang has the first publication about that, and Grillo develops this technique. And I think many surgeons will know it very well in this technique. And simply speaking, as it is, we divide the stenosis part exactly at the middle part of the stenosis part, And then we make a incision anteriorly and posteriorly in the proximal and the distant part of the trachea. And it depends on if you take the anterior in the proximal part, you will take the posterior in the distant part, or vice versa. But from my technique, I always take the anterior in the proximal part and the posterior for the distant part, because that's my technique only. And then after that, we slide in the two parts together. And if we divide the stenocyst part exactly at the middle of stenocyst segment, sliding will be very beautiful, like in the image you can see that. But it's sometimes it's not possible, because sometimes we divide it, and some is shorter and some is longer. And with sliding technique, we have to think about that. We have to reckon about how to merge them together before dividing exactly at the middle of the stenocyst part. And this is another technique when the stenocyst involved into the bronchi, for example. But actually, we have almost 100 cases. We have never adopted this kind of technique. And it is completely not necessary. On the right side is our patient with tracheal bronchitis, but we always divide it at the carina, and we take the carina, it's enough. And dividing like that is sometimes it's not good, but you can see it in the paper slide tracheoplasty in this paper that I just take several days ago, and I found this is maybe I'm not sure about that, but in the paper they say that only several single cases. But in my techniques, we just divide it at the carina, that's enough. And we no need to do the bronchus. Or if we have to go that, we go just a little bit, no need to divide like that. So how about to manage the sling? Sling is the technique to manage the sling is a little bit complicated, because the sling, the pulmonary artery is very small, especially when the children have the 2 or 3 month neonate, and they have only 20 or 3 kilograms, very small children we usually have. And the pulmonary artery is really, really small. If we transect it and re-implant it, the risk of obstruction, or maybe how to say, the obstruct the pulmonary artery is very high, and the mortality is also high also. And that's why we use the transposition technique versus we don't use the re-implantation technique. But in the literature, you can see, you will see many authors still use the re-implantation technique. But for us, we do 100% transposition technique, and we found it it's extremely useful and very good for in our series. So this is the anterior tracheal translocation or transposition, whichever you want to say. So when you see on the left side, when something to sling to each other, if you want to solve these problems, you have to cut either pulmonary sling or the trachea. You can cut either. But trachea, you always have to cut, because sliding technique require transect the trachea. So no need to transect the pulmonary artery sling. And we sometimes we try to find the middle point of the tracheal stenosis, as I said before, and we cut the trachea, and we relocate the pulmonary artery, or we shift the pulmonary artery to the left side, and to make the bifurcation of the pulmonary artery exactly in front of the trachea, and it worked very well. This is how to manage the sling. So as you can see in the yellow circle is sling. And the trachea we divided, and the point to divide the trachea, we calculate, we have to reckon at exactly the middle of stenocyst part, and this is very important. Sometimes the point at middle of stenocyst part is not the point to sling with the pulmonary artery. So we have to shift the trachea, how to move the sling to that kind of the transection, and to take the sling come to anterior to the trachea. And then we do sliding technique posteriorly for trachea. And how about the tripod? The tripod is, so you can see on the left side is a pre and the right side is post-operative technique in one of my patients. And when we perform sliding technique, very good. The tripod is no need to repair. The tripod is okay, but above the tripod, the tripod carina, if the trachea is stenosis, the children will have symptom. But if you solve this problem, you make the patency or the lumen of the above carina is good. So the patency, the lumen is well. So the tripod trachea bronchus is okay, even it's a little bit small. And how about the breath bronchus or two carina repair? This is the most significant challenge technique because there are several techniques was proposed. The first one is to translate, to cut, to remove the breath bronchus and to merge the two carina into one. And as you can see in the upper part of my image. So we resect the bronchus, the breath bronchus, when we move the lower carina to upper part, but sometimes it's not all. But later we also slide the second the breath bronchus also. So there will be two sliding parts. The first one in the trachea and the second one in breath bronchus. The reason is we don't want to sacrifice any part of the trachea. So these three parts become one. And sometimes we sacrifice one branch of the tripod. And it also works very well. We don't understand why, because one bronchus go to the upper lobe in the right side. But when we sacrifice that, the outcome of children is also very good. I'm not sure, but maybe some air from the lower part come to the upper part. And this is the typical sliding tracheoplasty image. And another, yes. And this is pulmonary artery sling, ante-tracheal translocation, that we transect the bronchus and we shift the pulmonary artery anteriorly. And also we published a paper about our data, 5 years later, and published in Journal of Cardiovascular Thoracic Surgery. And the last part, I will introduce a little bit about our series of that. So we have, in the 5 years up to by 2017, we have almost 50 patients operated. And the range is 3 months to 34 months. And we have several K VSD and imperforated anus, and sling is 63% as I introduced before. And this is tracheal structural anomaly. So the stenosis only, it means that no change in the shape or aberration is about over 30 cases, half of them. And breath carina or double carina, we have about over 10. Tripod carina, about 5 or 6 cases. So the pulmonary artery sling is 60%, over half of our series have a pulmonary artery sling. And the result for surgery, we have a single operation, and we have a so 47 cases have good results. Excellent result is 43, and good results we have 1, and mortality is 3. And the 3 mortality usually very severe patient before put in the ventilator. Even the children have cardiac arrest before the surgery. But re-stenosis, we have 2 cases, and almost happened in our several first case, in the first 5 or first 10 cases when our technique is still not so good as later. And we do it in 3 mortality case and 1 case when we reduce die. So conclusion, CT scan and tracheal endoscopy are enough to make the diagnosis for congenital tracheal malformation. And slide tracheoplasty show excellent results in our series. And ante-tracheal translocation is safe, and we use it 100% to manage the pulmonary artery sling. And the lesion should be repaired before the child have severe pneumonia and under ventilators support, because when we make the diagnosis or we have to think about the surgery, we have some children can limit by themselves and they can become a grown up, they can grow up and become adult without any symptom and compromise the pulmonary function. But some will be get sick and get in repeat pneumonia and put under ventilator. And when the patient have a multiple infection and ventilators repair seem to be very challenging. And how about the adult? We also adopt sliding technique to adult as well. This is the lady is 20 years, 19 years old girl, have tuberculosis, post-tuberculosis, stenosis, distortion of trachea, and very long path. And before we have a patient like that, we transect and to do end-to-end anastomosis, and the tension is so severe because you can see it's almost trachea was stenosis. And this previous children was after that died because the tension, as you cannot. But later we do slide tracheoplasty for TB, post-TB trachea is the result, excellent. The child, the girl recover very well, and now she live very normally. And thank you for your attention. Yes.
So I would like to say thank you, Vu Huu Vinh. And now your presentation is very excellent, and what you did is very excellent as well. And now the floor is for Q&A session. And I find two QQs. The first from Dr. K and to Dr. Adil Sadiq. So Adil, can you see the question?
Yes, I can see the question.
Yeah.
Thank you so much. So let's address the, go ahead.
Yeah, you can answer live.
Great. Thank you so much. So we'll answer the first question live. Thank you very much for the question. What kind of an agent do you use for chemical ablation of the bronchogenic cyst? Typically in the initial part of my career, we used to use phenol and then irrigated with saline. But then after working with my mentor, Dr. Miller in the United States, I've been using 10% povidone iodine most of the time. So for any kind of cyst wall that's left behind, we make sure we strip the lining of the cyst wall. 1, 2, we take electrocautery on a spray mode at around 20 coag units and buzz the entire area where the lining was there. And thirdly, I also use 10% povidone iodine concentrated that's in there. We rub it into the wall. We leave it for a good 5 to 10 minutes, and then we just suction it out. There's no need to wash it like we do with phenol. So that's what we use for chemical ablation. Some of the other surgeons that I've worked with have used even silver nitrate or ethanolamine oleate, but I've been sticking just to 10% povidone iodine off late. Sometimes, if at all, it's not available for some particular reason, I use absolute alcohol. So that's the first question. The second question, how do you detect and handle the fragile arterial supply in pulmonary sequestration? Once again, speaking from personal experiences, that can be a big bane, a big problem when dealing with sequestration. Always I'd like to say that we need to anticipate where the arterial supply is going to be. A lot of the times a good contrast MRI will tell you where it's coming from, or a good CT with contrast will tell you that. There have been instances when we've actually done, of course, in a young adult, a 13-year-old boy, we've done an angiogram as well of the descending thoracic aorta to actually find out that particular blood supply, and it was coming from below the diaphragm. What's interesting in this particular thing is a lot of the sequestrations are on the left side, and for most of the people who have left arch, the descending thoracic aorta is also accessible to you. So what I always do is try to get a loopy around the proximal and distal part of the aorta, just as security in case there's any kind of bleeding that I can't see. So I think preempting and knowing where it is very important, as I've said in the presentation as well. So try to know where that arterial supply is coming from before you go in. And if you know where that is from, you can always loop the aorta with an umbilical tape and keep a snuggle ready on it just in case you run into trouble. So I think that's the best way of dealing the fragile arterial supply. I've had the misfortune of having crazy kind of bleeding on table with an arterial supply which is kind of retracted into surrounding tissue. So I think it's better to be safe than sorry in those cases.
So let me add the question as the how to estimate or detect the fragility of the artery, and how to use the suture or stapler for division of the artery.
So I think every artery is fragile, no matter how you look at it, and every artery needs to be treated that way, just like we have any pulmonary branches out there. So most of the time when we have it out there, I actually use a fibroprotein suture across it on the fragile arterial supply. I always like to go to the base of it and take it down there. So that's how we take it out. Yes.
So you don't use staplers.
No, not for sequestration. I think I think it's easier for me to go ahead and put a 5-O protein or a 6-O protein at the base of that. I think I'm a little traditional, old-fashioned in that.
The second question is to Dr. Vu, and the question is that do you always use cardiopulmonary bypass during tracheal surgery?
Yes.
As I noticed from the presentation, most pictures have bypass cannulas on, and any particular conditions you did not use CPP. That is asked by anomalous attendees. CPP? I do not know who's cardiopulmonary bypass.
Yeah, all the cases was under cardiopulmonary bypass. We use heart lung machine for the better everything. But in the future, we may think about the ECMO, but we have not tried that.
No. So that's another question from, I think, the same person. So do you use sliding technique for tracheal reconstruction in post-intubation tracheal stenosis cases?
Yes, we do. But post-TB tracheal stenosis is very rare.
No, not post-TB, post-intubation.
Post-intubation, no. Post-intubation, the stenosis is very hard, and we just transect and end-to-end anastomosis. That's enough. We can do for all kind of all part of the stenosis post-intubation, even in upper crina or in. We have about over 100 cases of post-intubated stenosis repair very well.
So the site of stenosis after post-intubation, where do you find the site, the common site? I think is the upper part rather than near the crina.
Yes.
Yeah. And shall I go to another question to Dr. Adil Sadiq?
Yes.
So can you find the question?
Absolutely.
From Dr. Kazi.
That's correct. Thank you so much, Dr. Kazi. A real-time question with a 6-month-old child who has bronchogenic cysts seen in the CT, and specifically the child has been symptomatic with recurrent RTI, and also has had a first episode of dyspnea and cyanosis. So, and I think the cyst, as mentioned by you, is between the lower trachea and the esophagus. And so what is the approach out here? Do we need to go in for an immediate excision or wait till the child gets older? Well, 6-month-old child, considering the child is probably around 5 or 6 kilos at least, if the child is otherwise well-nourished, I think I would go in for surgery earlier, specifically for 3 reasons. The child already has recurrent infections. Secondly, the extent of dyspnea has been severe, so much so that the child is presented with cyanosis. So I think waiting on him is not going to give us much benefit. We're going to have recurrent episodes further to go on, and the first episode of cyanosis is gone with the second cyanosis. So I would go ahead and advise to intervene for the child at this particular age. Now, there are some caveats to my answer, and I would not intervene if the child is malnourished for some reason, has not gained significant weight, has any other intracardiac problems, and all these things, including nutrition, need to be addressed for a period of maybe 1 to 2 months. And if you think that child is going to get better on these accounts, we can delay the surgery for maybe 2 months and then take him out then. But primarily healthy child, 6-month-old, 6 kilos weight, go ahead for surgery.
I think the question has been answered. And there is another question from Inzing Su. So he said, thank you, Dr. Vu, for the great talk. And Dr. Vu, you can see the question, I think.
I can see the question. Okay. Okay, I answer this question. It is very difficult to predict how far from the sternal notch or cervical incision. I mean that we cannot predict that. In practice, we try in the cervical incision, whatever we can. But if it's too deep, and it is different from the patient to patient, and it seems to be dangerous, we don't hesitate to make a half sternotomy upper part, or in some case only 2 or 3 cm or of the upper part sternotomy. That's enough to control the innominate vein and artery. That's enough, and to make the stenosis. And there are no difference between the kid and the adult, but because stenosis in the kid is very, very rare. I have done about 10 cases stenosis in the children, small children with the trauma and maybe iatrogenic to make the stenosis, and post-intubation also have it. We have never to perform sternotomy partly. We can perform it in the neck only because the children have very easy to move, to mobilate the trachea and also control the innominate vein and artery. But in the adult, when we meet difficulty, we don't hesitate to make a upper part a sternotomy. Is it clear?
So I think you answered well, and so I found no more questions, and so shall I conclude the session? But there are a few things to talk by Dr. Soon about the CYTS program, and before Soon's talk, let me conclude my session by saying thank you very much to all speakers. So covering a wide range of topics, and they are excellent presentations and very informative presentations. So I'll hand it over to Dr. Soon for further information about CYTS webinar program. Soon, take over, please.
Okay. Thank you very much, Prof Tint. Thank you to 2 amazing speakers, Dr. Adil and Prof Vinh. That was really educational for me. We have been running this CYTS School of Surgery for the past 10 weeks now, in conjunction with Medtronic. We've covered a wide range of topics from all the way from majority lung cancer to congenital lung diseases for this week's talk. We want to thank Medtronic for their kind sponsorship for the past 10 weeks. They have been a valuable assistant and a contribution to our society. However, over the next few months, we're going to move on to technology in thoracic surgery. So we have a partnership with other companies coming up. For the next 3 weeks, we're partnering with Baxter, presenting on aerostasis and hemostasis. For the first part of September, we're going to talk about surgical robots and with partnership with Surgical Intuitive. And the later part of September, we're partnering with Olympus, talk about cameras, visualization, and localization techniques with their camera stack system. We also have lined up a lot of topics with the oncological companies for the later part of the year, especially in October. I'll keep you posted once we finish the next 3 series. So keep joining us, keep being educated. Thoracic surgery is flourishing across the region. We have many attendees from not only in Southeast Asia, but across the world, from Australia, from Bangladesh, from India, from Russia, just across the world. So feel free to encourage your friends and colleagues to join in as well. We will provide a certificate of attendance for every single talk that you attend. So as part of your education program. So for the next 3 weeks, that we are going to be partnering with Baxter. The next Monday, we're going to be talking about lung transplantation from a Southeast Asia perspective. The speaker is going to be Dr. Lim Chong Hee from Singapore. And the Baxter rep will be by Dr. Raghav. He is going to speak to us about novel dual-action hemostatic and sealant collagen patch in thoracic surgery. Then the following week, we're going to talk about management of air leaks in emphysematous lungs by Dr. Cynthia, also from Singapore, and how we can prevent postoperative air leaks, the substances out there that will reduce the amount of air leak when you perform surgery in patients with very fragile lung tissues. Then we're going to move on to ECMO talk. And I'm going to talk on the usage of primarily flow-seal and co-seal in thoracic surgery. So with that, 3 weeks in mind, so please join us. We'll be putting this up on our website. So our website is www.seats10.org. We have uploaded the past 9 weeks of talks onto the website as of yesterday. We are also uploading videos, techniques of surgery. So please visit our website and log on and have a browse through. We encourage you to join us. There's a section for membership. Please join us. Certain contents are for members only. And as we're developing this website, I'm sure that you'll benefit from joining us. So with that, I thank you very much for your attention. We'll see you again next week. Thank you again to Prof Tint, Dr. Adil, and Prof Vinh. Thank you very much.
Thank you. So,
Bye.
bye.
But, so let me add some agenda about Q&As. And I think Dr. Vu will answer some two questions that there was pending. Yeah. So the first one is from Dr. Li Pongtong. So have you ever used the thoracotomy for thoracic tracheal stenosis? Thoracotomy or any other access?
I see. For the access for tracheal stenosis, before we use thoracotomy, but now we never use thoracotomy because if trachea is the upper part of the lung, we can access from the neck. Whenever we go deeply into the almost crina, we always use sternotomy, and half upper sternotomy is good enough to control everything. And controlling the aorta pulmonary artery at crina is very important to move the crina up and to reduce the tension of the stenosis, because we have to research the stenosis part and to do end-to-end anastomosis. Yeah, so we never perform thoracotomy for tracheal stenosis or even any kind of surgery related to trachea.
Yeah. So they left another question from Yingxing Su that can I ask which the lowest level you can approach trachea via cervical approach instead of
I have answered this question already, because very difficult to predict how far and how deep we can manage through the next incision. Yeah, we have to think based on the individual surgery.
Now, since the time is quite overshooting, so let me conclude this session, and shall we meet again in the SEATS webinar. And thank you, Dr. Adil Sadiq, and joining us, and Dr. Vu Huu Vinh. So thank you very much and good evening.
Thank you, Professor.
Thank you. Bye-bye.
Okay. Thank you.